Good morning. Good morning, esteemed guests, distinguished speakers, and colleagues. Welcome to the Increasing Awareness and Understanding of Duchenne Muscular Dystrophy event here at New Giza University School of Medicine. I'm Kenzie Omar, a medical student here at NGU, and I'll be your host for this impactful program. I'd like to begin by welcoming the scientific director for this course, Dr. Rasha Sharif, for her opening remarks.
Thank you, Kenzie, for this introduction. Actually, welcome to New Giza University for the DMD educational course. I'm very thankful for our international guests from Iraq, Japan, Germany, and USA who join us today. And I wish you a fruitful sessions and discussions. Thank you very much.
Thank you, Dr. Rasha, for your words. DMD is a condition that profoundly affects lives, not just for patients, but also for families, communities, and all healthcare professionals that support them. The discussions we hold here over the next few days are a testament to our commitment to advancing understanding, research, and care for DMD in the Middle East. Through this program, supported by a grant from Pfizer Inc., we have the unique opportunity to deepen our knowledge, collaborate, and take actionable steps towards improving the quality of life for those affected by DMD. Now, to kick off our program, we'll begin with our first session titled Diagnosis and Genetic Counseling. Our chairpersons for this session are Dr. Nadal Ikyabi, lecturer of molecular pharmacology at the School of Medicine at NGU, and Dr. Mohammed Seher, lecturer of neurology at NGU and consultant of neurology at the Nasser Institute. Thank you.
Welcome, everybody. It's my privilege to introduce to you Dr. Christian Schaaf, Professor Dr. Christian Schaaf. He's the medical director and department chair of Institute of Human Genetics at the University of Heidelberg. He studies the genetic causes of neurodevelopmental, neuropsychiatric disorders. His work led to discovery of multiple new disease genes, and the 3 disorders has been named after him. So please, Doctor, I'm going to introduce you to the first lecture.
Well, thank you and welcome. Thank you to the organizing committee. It's a great honor and pleasure to be back at New Giza University. I was fortunate to attend one of those conferences 2 years ago and had the most wonderful experience. And it's great to see, even after only 2 years having passed, how much NGU has been continuing to emerge and to develop, and to see the campus expand, and to see the first 2 classes of medical students having graduated from the university. And I think there's really great momentum, and I'm happy to be a little part and to be able to participate in today's conference. So I am a clinical geneticist, and we will be discussing mostly the genetic causes of Duchenne muscular dystrophy and Becker muscular dystrophy today. And also I will be discussing some of the challenges and peculiarities of DMD genetics. So over the course of the next 2 days, you will get to know and understand and appreciate the clinical manifestations of Duchenne muscular dystrophy much better. And I won't go into much detail because I'm not a pediatric neurologist. But for the most part, and just to briefly summarize, DMD is a progressive muscular disorder, muscle wasting disorder. And in the case of DMD, which is the more severe form of the 2 dystrophinopathies, you will get to appreciate an increasing muscular impairment over the course of the first few years, such that the child, typically boys, will have more and more difficulty conducting certain tasks, such as climbing stairs. And as the condition goes on, they will lose muscular strength, stamina, endurance and abilities, and they will ultimately end up in the wheelchair, and because of the impairment of all the muscles in the body, including the diaphragm, and also having an impact on the heart muscle, the children do have a decreased lifespan. Now, if you do see such a child in your clinic, you may want to check the CK level in the blood first, because creatine kinase levels are increased, and in combination with the clinical features, that would then lead to a suspected diagnosis of DMD. It is caused by mutations in the dystrophin gene, and this leads to dysfunction of the dystrophin protein. In DMD, which is the more severe form, you will have absent or completely dysfunctional DMD protein that lacks the ability to connect the intracellular space with the extracellular matrix. In Becker muscular dystrophy, you will have a partially functional dystrophin protein. Both of those disorders are caused by mutations in the same gene, the dystrophin gene, which is located on the X chromosome. And the incidence of DMD is somewhat higher than the incidence of Becker muscular dystrophy. The difference between the conditions is really the severity, such that you have a much earlier onset of disease in Duchenne muscular dystrophy, which is typically within the first 2 to 5 years. And then it also progresses more quickly to the point that the affected patients with DMD are typically non-ambulatory within their teenage years, and the average life expectancy is somewhere in the 30s right now. But there are many new treatment options that are rising, and we will also be discussing these new treatment options at this conference, which hopefully will expand the life expectancy of individuals affected with Duchenne muscular dystrophy and Becker muscular dystrophy. Now, based on your clinical suspicion and in combination with an increased CK level, you may want to confirm the diagnosis of Duchenne muscular dystrophy or Becker muscular dystrophy by genetic testing. The genetic testing algorithm is not very straightforward, it's not very easy, and that is one of the reasons why oftentimes if you do have clinical geneticists on site in your hospital, you may want to consider to send the family to the genetics clinic for genetic counseling and the initiation of molecular genetic testing. We will come back to this testing algorithm a little later. But a lot of families are unsure as to what to expect in the genetics clinic because, compared to an internist or a pediatrician, this is not a medical specialty that they're very familiar with, and they oftentimes do not know what to expect. And this is not unique to Egypt or any countries in Africa. This is true in Germany, in the United States, everywhere. Medical genetics is a very small subspecialty, and many individuals in the population will never get to encounter a clinical geneticist. So at Heidelberg University, we prepared some videos, educational videos that we share with the families before their appointment, so that they better suited and better prepared towards what to expect in the genetics clinic. And I'm going to show you one of those videos.
Genetic counseling. What's the purpose of your appointment for genetic counseling? The aim of this appointment is to determine if a condition is inherited, and to discuss what this may mean for you and your family. Therefore, a physician will discuss your medical history with you, and will draw up your family history in the form of a family tree. In some cases, a physical exam of you or your child may become necessary after taking your medical history. Medical records of other affected family members may help determine hereditary diseases or congenital anomalies. Then, we will discuss with you whether genetic testing is warranted and which examination method might be the most suitable. A blood sample is required for genetic testing. For this blood test, we need your explicit consent. Your blood sample will then be sent to a laboratory where your genetic information will be analyzed. A few weeks after the blood draw, your test results will be available. At a follow-up appointment, we will discuss possible implications of your results for you and your child's treatment and preventative care, and what the results could mean for future pregnancies. In some cases, other family members might get a genetic test too, along with genetic counseling to explain preventive treatments and medical care. After your appointment for genetic counseling, you will usually receive a medical report. It summarizes your results and treatment plan for you and your treating physicians.
We've prepared several such educational videos, more general ones like the one that I just showed you, and then also some for specific indications and situations such as cancer genetic appointments. We have videos for appointments for children with disabilities and autism spectrum disorder. We have videos for prenatal questions. And I will get back and show one more of those videos towards the end of my talk, and that will also have a QR code that you can scan because those videos are freely available, and you can also use them in your clinical settings. So one of the specificities of Duchenne muscular dystrophy from a genetic standpoint is that it is inherited in an X-linked fashion. Boys have one X chromosome and one Y chromosome versus girls who have two X chromosomes. And the fact that women have two X chromosomes in most cases prevents them from developing the typical manifestations and the severe condition of Duchenne muscular dystrophy, because they still have one intact copy that prevents them from developing the severe disease. However, a mother who is a carrier for a DMD mutation can pass that mutation on to her boys, and then they who inherit the mutation from their mother will be left with only one but dysfunctional copy of the DMD gene, which leads to the classical manifestation of the muscle disease. So oftentimes we have pedigrees like the one that you see here. Squares indicate male family members, circles indicate female family members, and the condition and the genetic predisposition can be passed on within the family from generation to generation without any affected individuals, as long as it runs through the female line. But once a woman passes it on to her boys, then it will lead to the typical manifestations like the ones that you see here, with only males affected with the classical condition being uncles and cousins within this family. Given that information, you can draw a so-called Punnett square, which we do in genetics, to show which different situations can arise in a family where a mother who's a carrier for the mutation, shown on top, has children with a father who is unaffected, shown on the left. There are 4 situations, theoretically. 2 of those situations will be for the boys of that couple, and 2 of the situations will be for the girls in that couple. There's always a 50-50 chance for the carrier mother to pass on the mutation to her children. If that child happens to be a boy, then he will be clinically affected. If that child happens to be a girl, she will also be a carrier for the condition, but not typically have the severe clinical manifestations. And then there's a 50% chance that the mutation will not be passed on because the healthy X chromosome is passed on to the next generation, and then neither the boy nor the girl will be affected, and also they will not be carriers, and they cannot pass on the mutation by themselves. But sometimes female individuals with a DMD mutation can develop symptoms of Duchenne muscular dystrophy. And why is that? Well, that is related to the fact that X inactivation in the female body is a random process. At a very early stage in embryonic development, the X imprinting pattern is re-established in the cells that exist in the embryo at that time, and it's a random process for each and every cell. once the imprint pattern is established, then all the cells arising from those original cells will carry the same imprint pattern as the original cell. Now, because it's a random process, there's also a random distribution to it, like the one that you see here, just like any random distribution within the population. But even within a random distribution, there will be occasionally individuals who do not have a 50-50 distribution, but it could be 60-40, 70-30, 80-20, 90-10. And if it moves towards the ends of that spectrum, you could have occasionally a woman who has an unfortunate pattern of X inactivation called a skewed X inactivation. And if she has 95% of the cells in her body with the mutational X chromosome being active, then she herself may experience the clinical manifestations of the muscular dystrophy. There are other situations that can lead to females with the clinical manifestation of muscular dystrophy, not only skewed X inactivation that I just showed, but it could also be a woman with Turner syndrome. One of the causes for Turner syndrome is that the woman only has one X chromosome. And because she only has one X chromosome, if that X chromosome carries the DMD mutation, then she does not have a second X to compensate, and she herself will manifest the clinical features of the condition. Other rare situations include, for example, translocations involving the X chromosome and an autosome. So if X chromosome material is translocated to an autosome, like chromosome 7 or 16, then that will always be the active X chromosome, because the body recognizes that and needs to keep that chromosome active, because if the body inactivates the autosome, that would not be compatible with life. So that X chromosome needs to be active, and then if that X chromosome carries the DMD mutation, that woman will have Duchenne muscular dystrophy like her brothers, for example, would have. And then very rarely, you could also theoretically have females with two pathogenic DMD variants, for example, one that was passed on from their mother and then a de novo new mutation on the other X. The human dystrophin gene on the X chromosome is a very unique gene and is actually one of the largest genes in the human genome. You can see here it has 79 coding exons, and the setup of these exons plays an important role in the pathogenesis of the disease. Also, you can already see there are some exons marked as typical squares that have a nucleotide code in the coding sequence which is a multiple of 3. So the genetic code is always read in triplets, and if an exon is a multiple of 3, then that would be in frame if that exon is deleted. And then there's other exons which are not multiples of 3 that are indicated like those triangular shape exons. It also has several different promoters, and there are different isoforms arising from that gene. So genetically, it's very big and a little complicated. Now, it's relevant as to where the mutation arises, and we will get into the different types of mutations that we know, and which protein product which we would expect from the mutation. The normal dystrophin gene you see on top, which kind of connects the intracellular space with the extracellular matrix. And you need both the ABD domain on the N-terminal side of the protein and the CR and CT domains on the C-terminal side of the protein to establish that connection. If the C-terminal domains are lost, then that connection cannot be established anymore, and it will lead typically to the more severe form of muscular dystrophy. If something is cut out in the middle, but the connection between inner cellular and extracellular space can still be established, then the clinical phenotype may be less severe. The consequences of the dystrophin mutations you can see here. always comparing a normal muscle biopsy on top with a DMD muscle biopsy on the bottom. You can already see in the HE stain that there's infiltration, inflammation, fibrosis in the muscular tissue, and then in the specific stains you see on one hand that dystrophin is almost completely lost, but also laminin is very disorganized, already kind of showing that there are kind of these dysfunctional connections between intercellular and extracellular space. And then you see the fibrosis and the infiltration, also fatty tissue infiltration in the muscle. There are many different types of mutations that can cause dystrophinopathies. The most typical type of mutation are deletions. Deletions of certain parts of the dystrophin gene, which account for 60 to 70% of all DMD mutations and 80% of all Becker muscular dystrophy mutations. There are many other types of mutations, including point mutations such as missense variants, nonsense mutations, splice mutations, and more complex chromosomal rearrangements. The concept of the reading frame is very important to Duchenne muscular dystrophy and Becker muscular dystrophy. I mentioned that before, that there are certain exons that are multiples of 3, and then there are other exons which are not multiples of 3. Because the predominant mutational mechanism of DMD is a deletion, these are typically deletions of single exons or multiple exons within the gene. It becomes very important whether the deleted segment accounts for a multiple of 3 or not. It's the so-called reading frame rule. Because if it's a multiple of 3, then a part of the protein will be missing, but what comes before and what comes after will still be the same, and this may lead to a dystrophin that can still maintain a lot of its function. But if the reading frame is altered because the deleted segment is not a multiple of 3, everything that comes beyond towards the C-terminus will be messed up. It will be a nonsensical information, and that protein will not be functional, and you will be losing the domains thereafter. Oftentimes, the body will also recognize this and will lead to nonsense-mediated decay of the RNA so that you lose the dystrophin kind of more generally. So in the genetic reports, when we find a exon deletion in the DMD gene, we always try to determine whether the lost material is a multiple of 3 or not, because that can guide us and prognosticate which phenotype we would expect. Now, if you're testing a juvenile patient or an adult patient, you already know the clinic and you don't need the genetics to determine whether this is a more or less severe type, because the clinical phenotype is what you got, and that is better than any genetic prediction. But if you have, let's say, a young boy at the age of 2.5 or 3 years old who shows first signs of muscular weakness and impairment, and there's no family history, for example, because it's a de novo mutation or he's the first boy to that family, then this information becomes very important because the family wants to know what to expect. It's not a perfect prediction, but we estimate that in approximately 90% of the cases we can make a fairly good prediction as to which severity of phenotype to expect. And this brings us back to the diagnostic testing algorithms. So I've told you about the predominant type of mutations, and because these are deletions of exons or multiple exons, the first method that we typically suggest is a genetic method that will find deletions of exons. It could be a comparative genomic hybridization or chromosome microarray, or it could be an MLPA test, which is a test, amplification-based test that determines the amount of genomic material at certain locations. If that shows a deletion or duplication within the DMD gene, then you have your dystrophinopathy confirmed. If it shows a single exon deletion and you're not sure about the sensitivity and specificity of the test, you could do a confirmatory study and then through that confirm the presence of a dystrophinopathy. If you do the MLPA or the chromosome microarray and you do not find a deletion or duplication in the DMD gene, then you have to keep thinking, what else could it be? Which other type of mutation could it be that I have missed? And especially you would have missed all the single nucleotide changes, so missense variants, nonsense variants, splice site mutations. And then you need to order a test that would find those types of mutations, which if you have a strong suspicion for DMD, you would order gene sequencing, Sanger sequencing of the DMD gene, which is very time consuming because it has 79 exons, but that would be the appropriate test to do. If you still don't find a causative variant, then you're kind of back at square one and you have to think, could it be another muscular disorder? Do you need to consider other genes in the genome? Or if you still have a strong suspicion for DMD, you may want to do functional studies, do a muscle biopsy and do staining for dystrophin to see if the level of dystrophin is decreased, because it could also be a regulatory mutation, a mutation of the promoter of the DMD gene that causes decreased expression of the DMD gene and protein. So at the University of Heidelberg, we've been performing DMD testing since the early 1990s, initially with PCR and fluorescence in situ hybridization testing and also indirect testing. Then since 2004, we have the MLPA test, which is one of the gold standards of testing established. Since 2009, we've been offering whole gene sequencing by Sanger sequencing of the DMD gene. And since 2019, our center has been offering exome and genome sequencing for many indications, and we've also been getting the first cases of DMD through genome sequencing, and I'll show you one of those examples in just a few minutes. So our experience at our center is that if we do DMD testing after negative MLPA testing, we still find 42% of those cases positive for DMD, which means that yes, this is a valuable approach. If you have a clinical suspicion and the MLPA is negative, please think of the single gene and like full gene sequencing. And as I mentioned, DMD is an X-linked disorder, so we have multiple families that look like this, where the DMD mutation is passed on through the female line, and we have the males affected with the classic condition. This is also a frequent situation in our prenatal genetic counseling, where affected families come to the prenatal genetics clinic with an ongoing pregnancy, and they want to find out if the affected child carries the DMD mutation and if the child is a boy or a girl, which would then have consequences regarding their decision making. At Heidelberg University, we are also a center for pre-implantation genetic testing, and we have an increasing number of families also with DMD who want to make that decision before they become pregnant, because obviously it's a large psychological and emotional burden to terminate a pregnancy of a child that you've already carried for multiple weeks. So families who are affected with DMD can come to our pre-implantation genetic center, and they, if they decide to do so, they can go through in vitro fertilization, and then from the embryos that arise, we can take a few cells from each embryo, and we will determine whether the respective embryo carries the mutation and is a boy or not. And we would preferably only suggest to implant female or male embryos that do not carry the mutation at all. So if there are 8 embryos that arise from the IVF, you know, we can then say, okay, embryos 1, 3, 6, and 7 unaffected, do not carry the mutation. Those can be recommended for implantation. Out of all the cases that we've seen over the past years at Heidelberg University, when we do carrier testing for the mothers of the index patients, we see that 55% of those mothers are carriers. They test positive. and 45% are not carriers of the DMD mutation. I do think that kind of generally reflects what has been reported in the literature, that approximately 2/3 of all cases of DMD are inherited forms and approximately 1/3 are de novo forms. Now, I'm going to get back to our portfolio of genetic testing that we offer in Heidelberg, and I mentioned that we do have the first cases of DMD that are diagnosed by genome or exome sequencing rather than targeted testing, in part in cases where the testing is performed even before clinical manifestations of DMD arise. But it can also be found as an unexpected finding in the genome sequencing, and one of those cases I brought with me is a case that just happened to be diagnosed last week. It's actually a 27-year-old male with dilated cardiomyopathy. He presented to the cardiogenetics clinic because he has a dilated cardiomyopathy, which is very unusual in a presumably healthy 27-year-old male. And he underwent a diagnostic evaluation by whole exome sequencing and was found to have a hemizygous nonsense mutation in the DMD gene. So it is hemizygous. He is male with one X and one Y chromosome, which is important because you could also be a male with Klinefelter syndrome, which is XXY, and then you have a second X to compensate. No, he only has one X, one Y, and on the X he carries a nonsense mutation in the DMD gene. This, for me, was unexpected because he's 27 years old, and like in the medical history, there was no report of muscular impairment other than the cardiac muscular impairment. And interestingly, in the literature, there are some cases, especially males with nonsense mutations, that have been reported with isolated cardiac findings without the typical muscular manifestations of Duchenne muscular dystrophy. And I expect that through the widespread use of exome and genome sequencing, we will be seeing more and more of those cases. So with that, I brought with me another video, which is the video that we show our families and send to our families when we expect that they will undergo exome or genome sequencing.
Genome sequencing. In order to identify the cause of a possible genetic disorder, sometimes a very extensive examination is carried out. The so-called exome sequencing, or even a whole genome sequencing. For both methods, the genetic information, i.e. the DNA of a person, is extracted from a blood sample and then examined. DNA consists of a code of 4 different components similar to letters in words, A, T, C, and G. Different combinations of these DNA letters form genes that can be read during sequencing. If the sequence of letters is inconspicuous, a genetic cause for a disease is unlikely. However, if an alteration in the letter sequence of a gene is detected, we may possibly have found the cause of a disease. In order to read a person's entire DNA, whole genome sequencing is carried out. On the other hand, exome sequencing is used to examine the most important parts of all genes, the exons. Exons contain blueprints to produce proteins which fulfill a number of different functions within our cells. Reading the DNA is an automated process. A software analyzes the huge amount of data to find single alterations that could be relevant. In every person's DNA, a wide range of alterations can be found. Most of them are benign, but some of these alterations could be related to the disease in question. To estimate the relevance of the alteration, the program examines how common these alterations are in the general population. Additional information about symptoms or anomalies can also provide important clues. All found alterations can be compared in a database and filtered for potential diseases. Finally, the software sorts all detected alterations according to their relevance. Then, a team of experts examines which of these alterations might be the cause of the respective disease. In case there is a clear relation, the alteration is classified as a pathogenic variant. However, sometimes it's difficult to determine with certainty whether an alteration is actually the cause of a disease. Such variants of uncertain significance have no effect on medical treatment. Still, they should be re-examined in the future, as our current knowledge is constantly evolving. Finally, all findings will be summarized in a medical report. Overall, an exome and genome sequencing is an extensive examination. However, not all genetic diseases can be identified by means of these analyses. Often, cases remain unresolved. This is because we don't yet know the genetic cause for all diseases. It's also possible that the examination might reveal a secondary finding, a predisposition to another disease you did not know of. Before an exome sequencing test, you will therefore be asked whether you'd like to be informed about possible secondary findings, or if you prefer not to.
So, as I promised, I brought the QR code for you. All the videos that have been generated to date are kept on a website of our institute, and through the QR code you can get to the website and download and use those videos also for your clinical practice. The videos are available in German language and in English language, and also in English language with English subtitles if you want to. The website also provides a glossary of medical and genetic terms for your use, and also for the patients if they need this. So with that, I conclude my talk. I look forward to questions and answers and to Dr. Ahmed Ihab's talk, who will bring in the Egyptian perspective of DMD genetic testing and counseling. Thank you.
Thank you very much for your interesting talk, Professor Chaff. We'll open now for questions, starting with Dr. Rasha.
Professor Chaff, thank you very much for informative lecture as usual. I was very interested in the patient that had no skeletal muscle disease, although he has cardiomyopathy. This is very interesting because in our cohort we have some DMD patients who start having cardiomyopathy as early as 3 years, and actually this was like the first thing that I've seen in their face. He has heart failure, and other Becker muscular dystrophy who just present with cardiomyopathy, although they have skeletal muscle sorts. But in our case, we do direct genetic testing, so we didn't have the chance to do whole exome sequencing. Some theories says that there is maybe another gene that's involved. So because you already did the whole exome sequencing for this patient, did you find any other genes, or it's just the dystrophin?
Yes, so at this point we do not have any evidence for another gene kind of being affected in the pathogenesis of this disorder. But also because of the molecular genetic finding, we're now inviting this patient back into the clinic, and I want to do a more in-depth phenotyping of his neuromuscular phenotype. Also, you know, in the hospital system, he had never had a CK. So we need to go back and do what we call reverse phenotyping, you know, have the genetic information in mind and bring it back into the clinic to see. I would not be surprised if he already has some muscular impairment that was not as severe, so it was not brought to our attention before.
Yes, this is my other question, the CK and the EMG, but this is very informative for students and doctors to look for dystrophinopathies in cases of with cardiomyopathy. Thank you very much.
Thank you.
Okay, so we'll have time for only one last question to run with our schedule.
Thank you so much for your nice talk. I have the same question that Dr. Rash asked you about the patient with 27 years old. And I guess that the DMD must appear earlier. So if it appears in 27 years old, is there any other external factors that can stimulate the appearance of such case?
So if I understand your question correctly, you ask about the variable expressivity and the variability in age of onset of DMD.
Exactly, yeah.
So I think it goes without saying that you know, the clinical phenotype is not only determined by the mutation itself and the genotype-phenotype correlation of that particular mutation, but also by our genomic background in general. And genetic modifiers that may lead to a more or less severe phenotype, and then also environmental factors. And one environmental factor is actually our treatment.
Yeah.
I mean, we do know that things like corticosteroids, which are a very unspecific treatment, can slow down the progression of DMD. So that already indicates that obviously genetic, genomic, and environmental information kind of work together to determine the clinical manifestations.
Thank you so much.
Thank you.
Thank you very much, Professor Shaf. Allow me to welcome Dr. Ahmed Ihab. Professor Ahmed Ihab is Professor of Human Genetics at the School of Medicine. He's the Vice Dean for Research and Graduate Studies and the Director of the Health Sciences Research Center at New Giza University. He's also a visiting professor at University of Heidelberg, Germany. He's been awarded the Alexander von Humboldt Georg Forster Fellowship. He is also a member of the Egyptian Reference Genome Committee, and he's also been awarded the State Encouragement Award. Professor Ahmed's research focuses on the non-coding transcriptome in liver pathology, where he has recently got an approval of a patent in the field from the European Patenting Office. Please start, Dr.
Thank you very much for the introduction, Nada. Thank you, Professor Shaf, for the very interesting presentation. Actually, my focus today will be mainly on the challenges that we see here in Egypt concerning the medical genetics practice as well as the genetic counseling. First of all, I always like to show the New Giza University campus, which is a very modern one. And if we look here, it's just very close to the Grand Egyptian Museum. And sometimes we can have a look on the pyramids if we stay on top of the roof of the campus. First, I would like to give some, this is just a publication about the genetic counseling in the global state of genetic counseling in the world. So for example, we see that in the United States, there's the estimate number of genetic counselors about 4,000. In Cuba, which is in South America, is about 900 genetic counselors. In Saudi Arabia is 20 genetic counselors. And these I've chosen because we don't have really the profession of genetic counseling in Egypt as a real specialty. And the requirements for credentials or be accredited as a genetic counselor, it differs from one country to another. So there is the American Board of Medical Genetics and Genomics in USA. In Canada, there is also a similar board for specialization in genetics, even in Saudi Arabia. In Egypt, we still don't have this. So this is an estimate, a global map for the genetic counselors all over the world. I've chosen a couple of papers about the practice of genetic counseling in the region, so in Saudi Arabia as well as in Egypt. And this gives a bit about the number of consanguineous marriages among the Egyptian community. So, talking about the real challenges that we face in the clinic while we see patients during medical genetics practice and genetic counseling. So there are many. So training and certification, genetic testing, consanguinity, the cultural beliefs, the religious factors, the guilt feeling of some ex-mothers who are carriers for the X chromosome, X-linked conditions, and treatment decision for autosomal recessive heterozygote individuals. So let's start with the first thing, training and certification and medical practice. Most of the people working with genetic practice in Egypt are pediatricians actually. And they are mainly concerned with the pediatric genetics rather than the other genetics. It's divided among different specialties like pediatric genetics, medical biochemistry, clinical pathology, and molecular pathology. But as a real residency for medical genetics or clinical medical genetics, it has just started a few years ago in Ain Shams University, and I think that's what we're trying to establish with the Institute of Human Genetics, to establish a residency program here at New Giza University that would create a geneticist, medical geneticist, and at the same time to be a physician scientist. The second thing, genetic counselors. So in the Anglo-Saxonian system, the genetic counselors actually, they could be physicians, or they can be scientists with biological background who take a 2 years master and then they become a genetic counselor, but they cannot diagnose and they cannot prescribe medications. And the third thing, certification body. So we don't have yet what's so-called a board that grants the medical certification for medical geneticists, as well as the most important thing, that now who is doing the genetic counseling are physicians in different specialties. For example, in oncology, an oncologist who does the genetic counseling for the cancer patients, also for neurology and many other specialties. So it has to be a sort of a system, medical system, where there are some referrals from genetics, and that's what they always say or call it multidisciplinary team. So a neurologist works with a geneticist, works with a psychiatrist, works with a psychologist, and that is in order to have the right diagnosis and the right management of the patient. The second challenge with genetic testing. Genetic testing is very high cost, and actually sometimes it costs even than sending the samples outside the country, because many logistics are deficient, and that makes the test not cost efficient. Also, the availability of genetic testing is not available in every governorate of the Egyptian, in Egypt in general. It's localized to certain big cities, and not all the available testing is present in these cities. And the duration of the genetic testing takes a long time, so it takes about 2 months, maybe more, in order to get the genetic results. And that also represents a challenge when we have a patient who has to make a decision about his treatment in cancer. So that would make a challenge for us in order to wait for the testing result for the germ cell line or even for the somatic cell line, and make the testing and make the decision for treatment of the patient. And the third challenge is consanguinity. So it's estimated that the number of consanguineous marriages in different governorates of Egypt is between 27.3 to 46.5. And that's a very high, actually, percentage of consanguineous marriages. And the second thing, that when the family comes for genetic counseling, and we talk to the family members, actually, they are not convinced of having this to prevent marriages from the same relative. And that creates a challenge for us as physicians, because they insist to get married despite that they carry genetic mutations that's running in the family. The third thing is cultural belief. So whenever I do, and that I've seen many times in the clinic, when I do genetic counseling and genetic testing for patients, so they don't want to admit that they have a mutation, and they always refer this to that's because of envying. Our child is having this problem because of the bad eyes of other people who always look to our child because he's a beautiful child. And whatever you try or however you try to convince them, despite of that, they keep thinking that consanguineous marriages does not have to do anything with inheriting these genetic disorders, rather than having bad eyes from some neighbors or some family members. And the third thing is the religious beliefs. So, for example, in prenatal diagnosis in Egypt, it's accepted only before 120 days from conception. And if the baby is having untreatable genetic condition, in this case, with the approval of the family, it's allowed to have abortion, or pregnancy termination. But it's not possible that if the patients or the pregnant mother does not fulfill the criteria for termination of pregnancy, so usually they refer her to religious body like Azhar or whatever for taking a fatwa to whether to terminate the pregnancy or not. So it turned out to be a religious issue rather than being a medical issue. So that also represents a challenge because sometimes the pregnancy has a lot of risks for the mother and for the baby himself. The second aspect is the guilt feeling for community pressure. Whenever there is an X-linked condition, the mother usually feels guilty, angry, and she blames herself for having this X-linked condition. And it has nothing to do with her intention to have such an X-linked condition. So autosomal recessive conditions usually are not planned to have them, especially if they're X-linked. And that requires an adequate knowledge that should be given to the families about inheritance, about etiology, and educating the parents about that this has nothing to do with the mother herself, it has something to do with the genetic aspect of the family. And because also usually there's a strong social influence on the family, that this social influence would create such feeling of guilt among the mothers. And the last thing is treatment decision. So sometimes we have patients with autosomal recessive disorders, but they do not manifest, they're asymptomatic. And they do not manifest the symptoms of a normal autosomal recessive homozygous patient. For example, the familial Mediterranean fever. Nevertheless, those carriers, they manifest the full-blown picture of FMF. So, but they are autosomal recessive. So when you give the report for a physician or a pediatrician who treats the patients, he says, oh, it's an autosomal recessive disorder, it's a heterozygote, so the patient is not liable to take any treatments. And that's actually wrong, because usually colchicine in that case is a drug of choice, and the patient has to take the drug, but because of misinterpretation of the genetic report, usually they don't give the treatment for the patients. And here I'm showing some cases. This was a paper that we published a while ago about different, genotypes of patients with familial Mediterranean fever. So we have seen homozygous patient with single heterozygote with only one mutation, compound heterozygotes with many mutations within the MEFB gene, and compound heterozygous mutations. Whenever we see homozygous autosomal recessive disorder, this should imply that the patient is strongly symptomatic, he shows strong symptoms of the disease, and he has all the full-blown picture of FMF. But surprisingly, we did not find that. We found that sometimes single heterozygote patients might manifest more severe manifestations with a lot of amyloid protein that deposits in the tissues, regardless whether he's homozygote or not. So the manifestations, we've seen correlation between genotype categories and the clinical manifestations. We've seen pleuritis, monoarthritis, joint pain, and many other criteria have been found in single heterozygote patients. So usually autosomal recessive patients with a heterozygote state, they are amenable for taking the treatment. And it has nothing to do with with being homozygous or heterozygous in some cases. So that's why the treatment decision is very important in such cases. And another case, so there was a lack of linear correlation between the severity of symptoms and number and type of mutations. And the last case, or maybe this the last thing I'm going to talk about. So I've seen a patient in the clinic. She had recurrent attacks of respiratory tract infections, and she had amyloid protein, rendering her more amenable for FMF. And here we can see clearly that this patient, when we did whole exome sequencing for her, she had many other mutations and a heterozygous mutation in the FMF gene. And it was likely pathogenic. However, she was manifesting all the symptoms of FMF in addition to other immune disorders due to other mutations that have been seen in that patient. So she also had a heterozygous mutation in the CFTR gene, which means that she might be a patient, a cystic fibrosis patient. So usually the treatment decision has to be, very cautiously taken without just taking stereotypes that a heterozygous mutation for autosomal recessive disorder should not cause any disease. Thank you very much for listening, and I'm ready for any questions.
Thank you, Dr. Ahmed, for this elaborative lecture. So we have room for questions. So we have one question here.
Doctor, regarding patients, heterozygous patients who manifest symptoms, why is it even a question whether to treat them or not, since they're manifesting symptoms?
Because sometimes in the clinic, what we see is when they do the genetic testing and they find it heterozygous and autosomal recessive disorder, so the pediatrician believes that this is not a case where he should give the treatment for the patient. It has to be homozygous mutation, homozygous mutation for autosomal recessive disorders. So I see a lot of cases who are not taking the treatment for this reason, and it happens a lot in the clinical practice.
Okay, regardless of them having symptoms?
Yes, yes, yes.
Thank you very much, Dr. Ahmed, for such an informative lecture. From your experience in the genetic counseling clinic in Egypt, how do you see the Egyptians responding to the genetic counseling? Are they like reluctant to understand that this is an inherited disorder and they should do something before having another child, or the awareness became better nowadays?
There is improvement definitely in the awareness. However, that was not really something in the concept of the population to do genetic counseling. Sometimes even for cancer patients who have cancer mutations in the cancer genes and they have family history of cancer, they would rather say, "Oh, we don't know. We don't want to know about that. What would we do if we know such a thing?" Nevertheless, early detection means proper treatment.
Yes.
So, but by time, there's an improvement in the awareness among the general population. Yeah.
Okay. Thank you.
Yes, doctor.
Okay.
Question here, doctor.
Yes.
Is it understood why heterozygous patients, as you said, experience more severe symptoms than the homozygous patients, or is it still not understood?
Maybe Professor Schaaf might have an answer for that, but for me, it's totally understood, not understood why sometimes autosomal recessive disorder with the heterozygous state manifests more stronger manifestation than a homozygous state. Do you have a?
I think especially for familial Mediterranean fever, there's a lot both in genetics and also in the pathophysiology that we don't understand yet. Because from the genetics perspective, it doesn't make sense. You would expect that a homozygous individual is always more severely affected than a heterozygous one. But I think we have to understand that not everything that we see in the clinic kind of follows the rules of Gregor Mendel, and that genetics is more complex than we think, and sometimes more complex than we want it to be, which is a humbling experience also for us as physicians. We are now moving more and more in towards the era of genomic medicine rather than genetic medicine. And this brings into play what I mentioned before, the interaction of multiple genetic loci and proteins and variants to determine the clinical phenotype. We all have to understand that nobody has a perfect genetic code, right? The human's reference genome is not the genome of a single person, it's just the accumulated information from thousands and thousands of individuals, and each one of us carries hundreds of thousands of genetic variants, many of which will increase or decrease our personal risk towards certain clinical conditions. So this is also the era when artificial intelligence and machine learning become more and more important, because we need to integrate the complex information from the entire genome, which goes well beyond the things that we can determine and understand with our kind of very simplistic human mind. So I think in the next 10, 15 years, we will make tremendous progress in the integration, especially of polygenic risk scores, which many of them will also be used as genetic modifiers for monogenic disorders such as FMF. So, for example, in our genetics clinic in Heidelberg, we have started using polygenic risk scores to determine the individual risk for familial breast and ovarian cancer. Many of you may know of BRCA1 and BRCA2 and other breast cancer genes, which we tried to kind of use as monogenic causes for our understanding of familial breast cancer. But even in the background of such a familial mutation that dramatically increases your individual risk, your risk is not 100% to develop breast cancer. And it may be 40% or it may be 80% depending on the genetic background that you carry on top. So for that, we now start integrating polygenic risk scores that use the genetic information from approximately 250 other genes, of which we know that they modify that particular genetic risk. And we will see that in the genetics practice for many, many disorders in the coming years.
Thank you very much, Professor Shah. Thank you, Professor Iheb. Now we're going to move on to our next session.